Hello, I'm Hematologist Oncologist Dr. Tony Talebi, and this lecture pertains to the Hodgkin Lymphoma chapter of Hematology and Transfusion Medicine Board Review Made Simple. Hodgkin lymphoma has bimodal distribution. It peaks at 20 years of age and then another peak at 60 years of age. Classical histologic finding associated with Hodgkin lymphoma is the Hodgkin's Reed-Sternberg cell, a large cell that may be bi- or multinucleated, which contains large acidophilic nucleoli. This increased incidence of Hodgkin's seen in patients with autoimmune diseases and HIV, and that's due to the cytokine storm. Staging workup includes CT of the chest, abdomen, pelvis, or PET-CT scan, bone marrow biopsy, ESR, HIV, CMP, CBC, pregnancy test in women, excisional biopsy with immunophenotyping of lymphoma cells. There are two major subtypes of Hodgkin's, the classical and the nodular lymphocyte predominant Hodgkin's. The subtypes of Hodgkin's lymphoma, as far as the classical, include 1. Nodular sclerosis, next mixed cellularity, next lymphocyte rich, and finally lymphocyte depleted. These cells will be CD20 negative. The other major subtype is the nodular lymphocyte predominant Hodgkin's lymphoma, and this is the more indolent Hodgkin's, CD20 positive. Prognostic factors for advanced stage Hodgkin's lymphoma are by the IPS score. 1 point for male, 1 point for stage 4, 1 point for age more than 45, 1 point for albumin less than 4, 1 point for hemoglobin less than 10.5, 1 point for WBC more than 15,000, and 1 point for lymphocyte count less than 600. And the 5-year overall survival based on the IPS is 0, scoring 0 to 3, 80% 5-year survival, more than 4, 60%. Staging of Hodgkin's is similar to staging of other lymphomas in that stage 1 includes a single lymph node region or a single extralymphatic organ or site, that would be stage 1E. Stage 2 consists of 2 or more involved lymph node regions on the same side of the diaphragm or with localized involvement of an extralymphatic organ or site, that would be stage 2E. Stage 3 consists of lymph nodes involved on both sides of the diaphragm or with localized involvement of an extralymphatic organ or site, that would be 3E, or spleen, stage S, or both, stage 3ES. Stage 4 is diffuse or disseminated involvement of 1 or more extralymphatic organs, for instance, liver, bone marrow, lung, with or without associated lymph node involvement. All cases are subclassified to indicate the absence or presence of the systemic B symptoms of significant unexplained fever, night sweats, unexplained weight loss exceeding 10% of the body weight during the 6 months prior to diagnosis. The designation E refers to extranodal contiguous extension that can be encompassed within an irradiation field appropriate for nodal disease of the same anatomic extent. A single extralymphatic site as the only site of disease should be classified as 1E rather than stage 4. And as I said, designation S refers to splenic involvement. Classical Hodgkin lymphoma case report. 24-year-old female presenting with fever, weight loss, early satiety, has palpable cervical and axillary lymphadenopathy, so that's stage 2, splenomegaly, and pruritus, held below the diaphragm, stage 3. Elevated ESR, albumin 3.4, so that's 1 point for the IPS, WBC 10,000, hemoglobin 11, total lymphocyte count 1,000, excisional biopsy of lymph node reveals Reed-Sternberg cells with immunophenotype. This is very important to note. CD15 positive, CD30 positive, CD20 negative, and CD79 A weakly positive. CD45 negative, Epstein-Barr negative, granzyme negative, that's the T and NK cell marker. TIA negative, again that's T cell and NK cell marker. PET scan does not reveal any disease below the diaphragm and bone marrow biopsy negative. Immunophenotype to remember for classical Hodgkin's is CD15 positive, CD30 positive, and CD20 negative. That's crucial to know. The treatment of classical Hodgkin's, if it's stage 1 or 2 and no bulky disease, by bulky we mean if the mediastinal mass is less than a third of the diameter of the chest, that is not considered bulky, or no B symptoms, then ABVD is equal to MOP. And as we know, ABVD is adriamycin, bleomycin, vinblastine, and dacarbazine. And MOP is methchlorothamine, vincristine, or carbazine, prednisone. ABVD is equal to MOP but less toxic due to the fertility issues. So the recommended treatment is ABVD for 2 to 4 cycles plus radiation. If the patient has stage 3 or 4 or bulky stage 1 or B symptoms, then the treatment would be ABVD times 6 to 8 cycles. Remember, ABVD does not decrease a woman's fertility, and it may rarely affect a man's fertility. However, unfavorable risk, that is more than 3 IPS poor risk factors, then consider escalated Biakov regimen championed by the Germans. That includes bleomycin, etoposide, doxorubicin, cyclophosphamide, vincristine, procarbazine, and prednisone over ABVD. Radiation is recommended to sites if more than 10 centimeters to prevent local relapse. And just a side note, if PET scan is positive after 2 cycles, that's a very poor prognostic indicator. Treatment of relapse and refractory classical Hodgkin's. If relapse was more than 12 months after complete remission, then repeat chemotherapy. If relapse is less than 12 months after complete remission or primary refractory disease, then salvage chemotherapy regimen, and if chemotherapy sensitive, then consolidate with autologous stem cell transplant. Also, newly approved for relapsed Hodgkin lymphoma is the anti-CD30 monoclonal antibody brentuximab. Nodular lymphocyte predominant Hodgkin lymphoma, NLPHL. Favorite board's question. 30-year-old male presenting with localized peripheral adenopathy, stage 1 or 2, and hypercalcemia due to PTH-related peptide secretion. Excisional biopsy revealing immunophenotype CD20 positive, but lacking CD15 and 30. You must absolutely need to know this. NLPHL tends to be younger males, present with indolent and asymptomatic lymphadenopathy limited to peripheral lymph nodes. The immunophenotype of NLPHL, again, is CD20 positive, but lacks CD15 and CD30, the opposite of classical Hodgkin's. Despite an excellent initial response to combined modality treatment, patients with NLPHL tend to have a more indolent course and tend to relapse some years later, so will need surveillance for years. The benign nature of these relapses and the incidence of late treatment-related toxicity have raised questions about the need for an aggressive upfront approach at all. At the moment, the treatment recommendations for stage 1 and 2, no bulky disease, no B symptoms, are either consider observation as asymptomatic or ABVD 2 to 4 cycles, plus or minus rituximab, that's the important part, plus radiation versus radiation therapy alone. Now, if it's stage 3 or 4, or bulky stage 2 or B symptoms, then ABVD plus or minus rituximab for 6 to 8 cycles, and radiation therapy is recommended to affect the disease more than 10 centimeters. For relapse or refractory disease, patients may be salvaged with repeat treatments with either in-full field radiation therapy to areas of nodal relapse or chemotherapy plus or minus rituximab. Hodgkin treatment-related toxicity is very important to know since many young people are cured of Hodgkin and live a long time. Therefore, the toxicities are absolutely crucial to know and follow. Chemotherapy-related late toxicities include alkylating agent-related secondary leukemias, MOP-related infertility, pulmonary toxicity due to bleomycin, and anthracycline-induced cardiomyopathy. The radiation therapy-related late complications are secondary malignancies, commonly identified as breast, lung, GI, thyroid, and sarcomas. So, need to initiate diagnostic mammogram and breast MRI 10 years after completion of therapy. Also, accelerated coronary disease leading to early myocardial infarctions, hypothyroidism, so check TSH often, pulmonary fibrosis, and cardiac toxicity leading to congestive heart failure. This concludes the Hodgkin lymphoproliferative disorder chapter. Thank you.